2, 1. Please start, sir.
Yes. Good evening, one and all. My name is Satish Rama Joshikar from Zydus Life Sciences. I would like to welcome all our delegates and today's eminent faculty, Dr. Hariom Tyagi, sir. Without wasting much of our time, sorry for the sir was caught up in some cath lab, and then we have to start this meeting at 8:30. But I'm sure that we are eagerly awaiting to get kick-started this program of CLEARTalk. Without wasting much of our time, I would like to give brief introduction about Dr. Hariom Tyagi, sir. Sir is a director of Department of Cardiology, Lokpriya Heart Center, Meerut. Sir has proficient in evaluation management of acute and chronic cardiac diseases, arrhythmias, cardiac emergencies. He has special interest in preventive cardiology, acute myocardial infarction management, complex coronary interventions, heart failure management, etc. Sir is a regular faculty in many national and international conferences and presented research papers. So we are eagerly waiting for Sir to speak on Bemdac acid through the lenses of clear outcomes trial. A brief introduction about this is recent development in the field of dyslipidemia. That is the reason we started this CLEARTalk. CLEARTalk is one more facet of Unite Against Dyslipidemia. So without wasting much of our time, I would like to hand over this session to Dr. Hariom Tyagi, sir. Thank you.
Yeah, thank you. Good evening to all, and welcome to hear this discussed with this very important topic, in control of dyslipidemia, particularly in the known case of atherosclerotic cardiovascular disease patient. It is very important to control at the target level of the LDL cholesterol, particularly to reduce the further major adverse cardiovascular event in future to the patients. So this newer molecule, that is bempedoic acid, through the lenses of this clear outcome trial. So we all know that the LDL reduction, relative risk reduction of 1 millimole per liter of the LDL cholesterol, that reduce around 23% of the relative risk to the patient. So we have the different trials and maximum trials in support of the dyslipidemic, reducing dyslipidemia or control of the dyslipidemia in favor of the statins and other drugs like ezetimibe, fibrate, niacin, CETP inhibitors, bile acid sequestrant, ileal bypass, and PCSK9 inhibitors. Each 1 millimole, this decrease in this LDL reduction gives the more cardiovascular event reduction according to the number of years in trials and comorbid conditions as well. And after the 1 year of trial, around 11% reduction in the risk, and after more than 3 to 5 years, around 33%. And after that, more than 6 years, 36% relative risk reduction in cardiovascular events in the patients after the control of LDL cholesterol. So what are the problems in management of dyslipidemia is high on priority after the dyslipidemic or the coronary atherosclerotic cardiovascular disease patient. The priority is to give the statins to control the dyslipidemia to the patient. But the concern number one is, do all statin users achieve LDL goal as per the guidelines recommendations by the different societies? And second concern is how to achieve LDL target after maximally tolerated dose of statins. So the cardiovascular risk stratification, as we all know, we have the major risk factors for the developing further these events in the future. So major atherosclerotic cardiovascular disease risk factors are age more than 45 in male and 55 in female, family history of premature atherosclerotic cardiovascular disease, history of smoking and tobacco use, high blood pressure, and low HDL cholesterol. And depending on the risk group, we have the different risk group, the high risk group and very high risk group. If the patient have more than 3 major atherosclerotic cardiovascular risk factors and 2 major risk factors along with more than 1 moderate risk non-conventional risk factors, then is considered the high risk group to developing further cardiovascular events. And very high risk patient group in which the pre-existing cardiovascular disease are there, and diabetic more than 2 or other major risk factor including with diabetes or organ damage or familial hypercholesterolemia history. And last group is the extreme risk group in which the category 1 with the coronary artery disease is more than one feature of high risk group, or the patient have the recurrent history of coronary event or acute coronary syndrome, and despite the LDL control below 50 mg%. So the revised LDL target for the Indian population in 2020, it shows that the in extreme risk group in category A and category B, both our LDL goal should be less than 30 mg%. And for the very high risk group, Esteta, should be less than 50 mg%. And moderate to low risk group, it should be less than 100 mg%. In when we consider the drug therapy in patient with these all groups, low risk to moderate to high or extreme group, in low risk group, even after the control, this lifestyle modification, diet and exercise, if the LDL cholesterol is more than 130 even after the 3 months of lifestyle modification, we should consider the statin therapy or drug therapy to control the LDL cholesterol. In moderate risk group, if it is more than 100, then should be statin to be started. In high risk group, if it is more than 70, and for very high risk, if it is the LDL cholesterol more than 50, then drug should be started to control the LDL cholesterol. And in extreme group, it should be, if it is more than 30, because target is less than 30, should be started to control the multiple these antilipidemic drugs. So when we compare the 2016 ESC guidelines and with the 2019, so our this target is for the LDL reduction is decreasing because the risk is high risk categories in patient. The number of risk factors increase in this group. In low risk group, it is one less than 115 in 2016 and also in 2019 the same. But for the very high risk and high risk group, it is less than 70 previously in very high risk group, but now it is less than 55 mg% into ESC 2019. So as the cardiovascular risk increases, it needs to reduce the LDL cholesterol to the lower level as possible. Based on the revised ESC 19 guidelines, how many patients do have controlled LDL cholesterol? So this is the cross-sectional observational study of patient prescribed lipid lowering drugs for primary and secondary prevention. And the different European countries, 18 countries are included, and more than 6,000 are included in this one. For the primary prevention, 50%, and secondary prevention, 50%. Our aim and the aim in this study is to evaluate the impact of ESC 19 dyslipidemic management guidelines on LDL goal achievement. So this study, Da Vinci study, overall outcome to be observed, and in proportion of the patient. So as per the revised guidelines from the ESC 2019, in all patients, around 27.6% eligible patients are receiving high intensity statin only. And out of these, only the 30% patient achieved lipid goals with a high intensity statin. In a very high risk group, as the revised ESC 19 guidelines, only 37.5% eligible patients are receiving high intensity statins. And out of these, only 22% of patients achieved lipid goal as per guidelines with a high statin intensity statin. So our second concern is how to achieve LDL targets after maximum tolerated dose of the statin. So in atherosclerotic cardiovascular disease diagnosed patients, so check the baseline LDL cholesterol. If the patient have the atherosclerotic disease already, means ACS or stroke or peripheral artery disease, with high intensity statin, only the 50% of the patient achieve the target level of LDL, high dose of. But if we add the azithromycin to high dose, 65% achieve this target level of LDL. After adding the high dose to the peptide acid, the number increase around 5 to 7. And if it is included azithromycin along with the statin acid, then it is around 25% achieve target level of LDL. And after adding PCSK9 with the azithromycin and high dose statin, is around 80% target achievement. In familial hypercholesterolemia, with the high dose statin and ezetimibe, only 65% of patients achieve lipid target this criteria. But after adding bempedoic acid along with ezetimibe and PCSK9 inhibitors, around 85% or more than 85% of patients achieve target level of LDL cholesterol. And in patient, if they are completely intolerant to statins, then we have the option of ezetimibe and bempedoic acid. They achieve target 40% patient target achievement. But after adding to the ezetimibe and bempedoic acid and PCSK9, then 80 to 85% of the patient achieve target levels. So high dose statin intensity statin has drawback because they have low adherence, which leads to higher adverse cardiovascular events. Observational study of around more than 23,000 patient post-acute coronary syndrome patient were prescribed high dose intensity after index events. Around 66.4% of all patients presenting with the ACS did not take high intensity statin after the discharge due to some side effects or reasons or cost also. And more than 50% of patients had drug interruption and end of therapy within the first month after the index event. Non-adherence to the high intensity statin had a strong association with high mortality, around increase around 16%. So it is a significant p-value of less than 0.001. So this newer molecule is beneficial in this regarding. This is bempedoic acid, ATP citrate lyase inhibitor, ACL inhibitor, the first in class and LDL lowering group. So this introduction regarding bempedoic acid is approved in countries US, Europe, and India. Approval in year 2020 in US and Europe. And indication for approval is reduced uncontrolled LDL cholesterol with maximum tolerated statin dose, and mixed lipidemia, familial hypercholesterolemia, and high risk for atherosclerotic cardiovascular disease patients. And number 3 is statin intolerant or whom the statin is contraindicated. Dose of bempedoic acid is 180 milligram orally with or without food. This is a novel. This bempedoic acid inhibit the ACL enzyme, that is the upstream to the HMG coenzyme reductase, and it is not activated in skeletal muscle. So management, how we manage the patient receiving bempedoic acid therapy, the half-life around 21 years, 21 hours, and elimination 70% excretion of total dose through the kidney, 5% through the feces, and 2% unchanged drug through the kidney. There is no concern in renal and hepatic impairment patient. We can give without dose modification, but we should be careful or monitor in patients, the uric acid is higher or the history of gout is there. If the patient have more than 60 years of age, taking steroid or fluoroquinolones with renal impairment and a history of tendon rupture. This should be avoided in pregnant breastfeeding female or patient who taking high doses of simvastatin or pravastatin, and also in patient with 60 years, more than 60 plus, who was taking steroid or have tendon rupture, then should be discontinued. The outcome of this CLEAR trial, it shows that the cholesterol lowering via bempedoic acid and ACL inhibiting regime This is the late breaking clinical trial in ACC 2023. It shows that the cardiovascular outcome study of the bempedoic acid statin intolerant patient with elevated LDL cholesterol. Primary and secondary prevention patient with elevated LDL cholesterol and statin intolerant. The primary endpoint is the effect of bempedoic acid versus placebo on 4 components of major adverse cardiac event like cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, or coronary revascularization. Number of patients included in this was around 14,000, and median follow-up is around 40 months. So the primary and key secondary endpoints, primary endpoint, 4 component major adverse cardiac event like coronary revascularization, cardiovascular death, non-fatal MI, and non-fatal stroke. And hierarchical testing of the key secondary endpoint of 3 component of this: fatal, non-fatal MI, coronary revascularization, fatal, non-fatal stroke, and all-cause mortality and cardiovascular death. So the effect of trial regime on cardiovascular events, along with statin intolerant patient, treatment with this bempedoic acid was associated with lower risk of major adverse cardiac events, and 4 components of major adverse cardiac event around 13% reduction, and 3 component major adverse event reduction around 15%. Myocardial infarction reduction is around 23%, and 19% coronary revascularization. So it significantly reduced all adverse events and myocardial infarction and revascularization after the target achieve of the LDL cholesterol after adding the bempedoic acid. So the clear outcome, LDL and HS therapy reduction, we can see that the 21% reduction in LDL cholesterol after the end of the trial, and 22% reduction in HSCRP. So the conclusion of clear outcome study is that bempedoic acid becomes the first ACL inhibitor and first oral non-statin to demonstrate the statistically significant reduction of MACE-4 events in patients who are at high risk of cardiovascular disease with documented statin intolerance and elevated LDL cholesterol. So in conclusion, we can say that it is an effective alternative to statin or high-dose statin who are intolerant to high-dose statin patients. Clear outcome shows the well-tolerated in a mixed population of primary and secondary prevention patient unable or willing to, who are unable to take statin or unwilling to take statins. And also the LDL and HSCRP reduction is around 22%. Small increase in incidence of gout and cholelithiasis is seen with bempedoic acid. Primary endpoint and secondary endpoints already discussed. 4 major adverse event component around 13% reduction, and 3 major component around 15% reduction. Myocardial infarction around 23% reduction, and revascularization around 19% reduction. So the effective approach of bempedoic acid to reduce the major cardiovascular events in statin intolerant patient. Thank you very much.
Thank you so much, sir. There are a few questions online I have, which we would like to ask, and then we'll answer the queries from the audience and our delegates today. So this first question is about, you earlier talked about ESC 2019 guidelines. Lower is the better, but how low one can go, one can target? How is there any neurological complication if one goes below 30 milligram per deciliter of LDL cholesterol?
Yeah, so previously we all these guidelines and studies shows that the less than 70 milligram percent and less than 55 milligram percent later on came to know that lower of LDL cholesterol is better to reduce the major adverse cardiovascular events, particularly the non-fatal MI, non-fatal strokes also reduction, and cardiovascular mortality, and also the all-cause mortality also reduction in there. So the significant reduction is around 20%, and also revascularization reduction is there. If we achieve this LDL cholesterol within target, in particularly the extremely high risk patient, in whom the all high risk high risk factors are there. Very high risk factors are like established atherosclerotic cardiovascular disease, like peripheral arterial disease or coronary event are there, or stroke is there. In these patients, we are very careful to achieve the LDL level at the minimum level, if possible, with the statin, or if the add-on therapy with ezetimibe, bempedoic acid in oral regime.
Yes, sir. And when we are talking about statin intolerance, how in your clinical practice you come decide that this patient is having statin intolerance?
Yeah, in the initial phase after the ACS of the intervention, when we prescribe the high dose statin for some times, then the patient develop some the like myalgia and other. If the patient have liver this parameter deranged, like that also we have to be reduce the dose therapy, and main concern to the patient is the myalgia only.
Okay, sir. There's one question is about diabetic patient who is on statin, conceived, confirmed pregnancy at 10th week of pregnancy. So, what are the adverse effects in pregnancy or for fetus if we prescribe bempedoic acid or statin?
Yeah, so clear cut. They say that they should be avoided in the pregnant female and also the in breastfeeding females.
Okay. Sir, there is
Should be
one question
given
is
only. It should be given only if the benefit of the prescribing or the achieving the ideal goal is
yes,
beneficiary
sir.
higher than the negative effect on the.
So there's another question is at what age or at what level of LDL level we start statins in congenital dyslipidemia, and we can whether we can add bempedoic acid as we are detecting high levels of LDL in adolescent age or young adults.
High level of LDL.
Yes, high levels of LDL.
Yeah, the familial hypercholesterolemia cases like we have discussed in this one. We have the many patient. I have already around 10 to 12 patients like with familial hypercholesterolemia. With we are resistant to control with the high dose of statins. Then in such cases, we have to give the multiple therapy. Previously, we have given in 2-3 patient PCSK9 inhibitors also, but most of the patient were not very keen to give this PCSK9 inhibitors. But after coming this bempedoic acid, we can give combined with the ezetimibe, statin, and the bempedoic acid to control the better control, near equivalent to the PCSK9 inhibitor with the give combined all three agents. But previously, I have seen many patients with the LDL cholesterol is more than 300, like that 200, 300, and resistant to control with the high dose statin. In such cases, the future events, cardiovascular event or recurrent acute coronary syndrome events is higher in such patients who have already have developed one episode previously, and also in the family. If we screen those family, then the many patients have family history like that. So the brother and sister also have this high level of the LDL cholesterol. So in such patient, we have given this combination therapy, and they achieve better than the high dose statin therapy.
So this next question is about can it be used in ACS patient or how long it has to be used? What is the mortality benefit of bempedoic acid?
Yeah, so the three criteria I have mentioned here, the revascularization, mortality benefit, and the major adverse cardiac event, both 4 and 3, around 15 to 20% reduction, like that they all mentioned. So the reason behind that, the uncontrolled dyslipidemia or the high level of LDL cholesterol further increase the cardiovascular event in the future. if the patient already developed or already known case of the atherosclerotic cardiovascular disease. So in such case, it is very beneficial to the patient if we achieve the LDL cholesterol as low as possible in such scenario. If there is no contraindication, we should add the add-on therapy other than statin with the bempedoic acid and ezetimibe.
I think, sir, we lost communication. So you are not perfectly audible.
Hello. Voice is not coming.
No, sir. Voice is properly clear.
Maybe some signal problem.
Satish sir, yours is internet problem.
Okay. You can hear me?
Yes, sir. Properly.
Okay. Maybe some internet problem from Satish
Yes, sir.
side. Nahi?
Yes, sir.
Okay. Okay then. Thank you. Thank you very much. Okay.
Okay, sir. Wait for 2 minutes. I think so. Satish sir will rejoin.
I think his signal gone. Nahi?
Sorry, sir, I lost my communication. So it was indeed a pleasure having you on this evening talking about clear outcomes trial and bempedoic acid. So any final closing remarks would you like to?
Yeah. So in nutshell, we can say that this clear outcome trial, it showed that in particularly to the statin intolerant patient who are not tolerating the high dose statins and the LDL is not achieved to the target level. So we should add the bempedoic acid that is well tolerated in mixed populations and also achieve the LDL, lower the LDL around 22% and also important point that is inflammatory marker that is HSCRP. HSCRP also reduced to the same level like 22%. Only concern is the small increase in incidence of gout or cholelithiasis to be keep in mind. And the major benefit is the primary endpoint and the secondary endpoint, both for the MACE 4 and 3 around 13-15% reduction, and also myocardial infarction around 23% and coronary revascularization of around 19% reduction in such patients. So it's we can say that the effective molecule and to reduce the major cardiovascular events in such patients, it's very good drug. We should add and achieve this target level with this.
Thank you so much, sir, for being with us. And from Zydus Life Sciences, I would like to especially thank Dr. Hariom Tyagi, sir, for being with us. And I also would like to thank all our delegates for your active participation in this clear talk. Sir, special thanks that you already cleared all our doubts on clear outcomes and trial and bempedoic acid. We were eagerly waiting for your deliberation on bempedoic acid through the lens of clear outcomes trial, and our audience must have received your expertise and in clinic experience, which will definitely help in day-to-day practice while treating the patients of dyslipidemia and high LDL cholesterol. So thank you, sir. Thank you so much. Thank you all the delegates. Thanks a lot once again, and hope such kind of programs in future will conduct, and definitely you will be a part of these programs in coming future also. Thank you so much.
Thank you.